To thanks BAMOS, Bangladesh Association of Oral and Maxillofacial Surgeons. The term is 2023 to 2025. And this is the second webinar organized by this term, BAMOS. And I would like to thank Professor Ismotara Haidar, who is the leader and the president of the BAMOS this session. And I would like to thank the Foreign Affairs Secretary and the Assistant Secretary, Dr. Abdullah Al Masood and Dr. Sajid Hassan, along with our strong IT department, IT Secretary, Dr. Mujri Mahmood and Dr. Apel Mahmood for organizing this session. And special thanks to our guest today, guest speaker, Professor Moni Abraham Kuriakose. And thank you so much, sir, for attending, for delivering the lecture. You are going to deliver the lecture. And this lecture is very, very interesting, I would like to say. And India, Pakistan, Bangladesh, Sri Lanka, the scenario is same. The gingival cancer is very common, and all our dignitaries are here, our legendary maxillofacial surgeons, as well as the trainees and the new surgeons and the old surgeons, all are here with the panel of experts, our great teachers and the colleagues. They will comment on your presentation and the discussion session. And I hope everybody will enjoy the session. And all of us know Professor Moni Abraham Kuriakose, I think so. And we are friends for the long time, and you came Bangladesh also repeatedly. So from all aspects, your presentation, your lecture will be enjoyable, and we'll enjoy.
Thank you, Dr. Anwar. And really appreciate the opportunity to address the BAMOS members, and grateful to Dr. Haider, Professor Haider, Dr. Abdullah, and Mansoor, and others who gave me this opportunity. As we heard, the title of my talk will be on management of advanced oral gingival cancer. And what I hope to do during the next 30 minutes or so is to cover this topic under these 4 headings. We will discuss what is meant by this advanced gingival cancer, and then what are the treatment options for these patients. Then we look at the technique of compartmental resection, and I will touch upon the oncological outcome of managing these patients. First of all, when we talk about advanced head and neck cancer, if you compare the head and neck cancer related to other common cancers we see in our part of the world, just to compare the breast cancer, the advanced cancer accounts for about 50 to 60% of all tumors. But compare that to head and neck cancer, the number increased to about 60 to 90%. And in our part of the world, it's mostly 70 to 80 or 90% are in advanced stage. So this is a common problem we see in our part of the world. And let me first define what I meant by that advanced gingival cancer. So if you look at the definition of T1 to T4 cancers, T4A tumors are those tumors of oral cavity involving skin or the mandible. Now, there is another advanced cancer called T4B cancers. These tumors are those involving the masticatory space or pterygoid plate or even skull base or internal, involving encased internal carotid artery. Now, this is when we're talking about involving the masticatory space, this is an area we're going to talk about. So we will go into more details of this area, but to show the case in point, a tumor such as this tumor that is on the buccal mucosa, if it penetrates or depth of invasion is about 1 centimeter, on the other side of that mucosa is a buccinator, and deeper to that will be masseter on one side and the medial pterygoid on the other side of the mandible. So this tumor, just by 1 centimeter depth of invasion, can involve the infratemporal fossa or masticatory space. As opposed to this tumors of the tongue, for this cancer to get into infratemporal fossa or the masticatory space, it has to go through multiple layers. So combining these two tumors together and calling them as T4B is not quite accurate. The error happens because the people who define these cancers or define the staging criteria for these cancers do not see this buccal mucosal cancer, but in our part of the world, it's extremely common. So it's our job to educate the rest of the world that these tumors are different, and we should not just follow what is dictated or written in the textbooks or in staging criteria or following the guidelines, and then we may make a wrong decision. And that decision making is extremely important. Case in point is a lady such as this patient, a tumor of the buccal mucosa coming out to the skin. On the way, it has involved the medial pterygoid muscle as well as masseter muscle. So this is defined as a T4B buccal mucosal cancer. To give this opposite view, this is a tumor involving the entire oral tongue, but still we are calling it as a T4A. I'm going to convince you that these two tumors are different, and the first tumor which I mentioned may not be, should not be classified as T4B. Now, the definition, if you define a tumor as in that level or in that category, there can be implications. For example, the moment you stage a tumor as a T4A, we treat the patient on a curative intent with surgery as the first line of treatment. But when we stage the tumor as T4B tumors, definition which I gave that involving the masticatory space, then look at the options are either clinical trial or concurrent chemoradiotherapy or radiotherapy or best supportive care, palliative type of care. Now, this is what we are supposed to do. And if you do that, let's look at what are the outcomes. This is a large study of almost 6,000 or almost 7,000 patients who were treated by surgery followed by post-op radiotherapy in advanced surgery followed by post-op radiotherapy. If you do that, the outcome of surgery followed by post-operative radiotherapy is about 53%, but just by giving chemoradiotherapy, outcome is only about 37%, about 16% below that of offering the surgery upfront. So giving chemoradiotherapy, you get a poor outcome. Now, another therapy widely practiced in our part of the world. Now, let's look at what's the data to show the outcome. There are two trials. First trial is from Europe by Lisa Lisitra, very old trial, about 195 patients. They gave induction chemotherapy. They used platinum and 5FU followed by surgery, compared that to surgery. And if you look at the survival outcome, exactly same. By adding induction chemotherapy, we are not improving the outcome, overall disease outcome in this patient. People question that, no, the chemotherapy regime used was wrong because used only platinum and 5FU. We missed that platinum 5FU and Taxol platinum 5FU. And this was tested by the Dr. Zhang's group from Shanghai. Again, look at the outcome, absolutely not different whether if you give induction chemotherapy followed by surgery or radiotherapy, there's absolutely no difference. So by surgery, you get almost exactly same cure rate as if you do induction chemotherapy followed by surgery. So induction chemotherapy doesn't add to the oncological outcome. Now, if you look at all that study, the previous study was carried out in resectable tumors. Now, from this study is from Kumar Prabhash group from India. They looked at unresectables, that patient which we were talking about, the T4B type of cancer. And I want you to look at that data outlined here. If you do induction chemotherapy followed by chemoradiotherapy, the overall outcome is 20%. But if you give induction chemotherapy followed by surgery and then radiation, the outcome is 58%. But if you do induction chemotherapy and surgery as above, but do not followed by radiotherapy, outcome is poor. So surgery followed by by induction chemotherapy, if you don't add radiation, it's as if we have not done the surgery. So this is the take home from that large study. Another study came out from the same organization. In this case, they took both the T4A and T4B tumors, and some of the patient underwent surgery, other patient underwent chemoradiotherapy, and look at the outcome. Whether the patient underwent T4A or T4B, the outcome is exactly same. T4A, the outcome was 65%. T4B, slightly lower, but still fairly manageable. But if you look at the patients with adequate surgical margin, if we resect with the adequate surgical margin, look at the outcome, 80% for T4A and almost 70% for T4B tumor. But inadequate margin, is almost very low, 7 to 12%. So positive margin is a killer when it comes to this advanced cancer management. So putting together, the question is how we can operate on these advanced cancer patients and get surgical margin. So that's a need to analyze the pattern of failure. Case in point is this patient with that buccal mucosal cancer. We did a composite resection. Flap was used for reconstruction. About a few months later, patient came with a dull aching pain around the temple region. PET scan showed a very recurrent tumor of the infratemporal fossa. And the further scan showed that the tumor had gone into the intracranial compartment. Definitely, we lost the patient. So why we lost the patient? That's a question we addressed in this study by Neera from our group. We looked at the pattern of spread of this tumor. Tumor from the tuberosity of maxilla can get into the pterygoid plate. From the retromolar trigone or buccal mucosa can gain access to infratemporal fossa through either temporalis muscle or medially on the medial pterygoid or laterally on the masseter muscle and gain access to infratemporal fossa. Once the tumor gain access to infratemporal fossa, it can go along the posterior of the maxilla by the posterior superior alveolar nerve to intracranial compartment using along the mandibular nerve. So with that in mind, we classified the tumors within the infratemporal fossa as a class 1 tumor. Those are the tumors involving the masseter or medial pterygoid, or the tumors involving the lateral pterygoid muscle, or more advanced ones are the class 3 ones involving the posterior wall of the maxilla extending to the inferior orbital fissure. So in this case, they're getting a negative margin is poor. That is why we classify it as a class 3. You may remember there is a classification by Taiwanese group or supra that is not quite accurate, because even a supra-notch tumor involving the lateral pterygoid, we can get a negative margin, but a infra-notch tumor at the pterygomaxillary fissure, at the inferior orbital fissure, even though it's below the sigmoid notch, you can get a positive margin. So that involving that area is very, very important to appreciate. Now, following on that, we developed a technique of resecting the infratemporal fossa by what we call compartmental resection of masticatory space. Essentially, what that involves is removing the entire compartment of infratemporal fossa as one block, along with, say, mandible or maxilla, depending on the primary site of the tumor. And this technique of compartmental resection is based on these principles. The pattern, the excision of tumor should not be based on just putting a finger around the tumor and removing, because the pattern of spread is different. Tumors favor certain anatomical structures for spread, for example, nerve and muscles and so on. But certain structures like bone and periosteum can offer resistance to spread. Now, the other issue is that if you resect a structure partially or completely, the outcome, the functional outcome is almost same. For example, a muscle divided partially or nerve divided partially do not function. So that the removing just part of the structure is not going to save your functional result. And there is a lot of data from the sarcoma that this compartmental resection work, but we do not have much data from the head and neck literature. So before I talk about that compartmental resection, let's spend some time to discuss the anatomy of infratemporal fossa. It's very important because infratemporal fossa is a very crowded structure, and we do not go there very often. So it's important for us to just recollect the anatomy of this region. Now, when we talk about the infratemporal fossa, it has got two parts. One is the masticatory space, which is space surrounding the mandible, on which or through which the muscles of mastications traverse. And then we have the parapharynx space. Parapharynx space are either pre-styloid or post-styloid. We will not be talking about this. We'll be focusing on this masticatory space per se. So talking about the anatomy of the masticatory space or infratemporal fossa, let me take you through using this illustration by Dr. Rotton's fantastic publication many years ago. This is a section, coronal, axial section from at the level of the floor of the orbit through the clivus. One side is the skin, the other side is a midline of the clivus here. Okay, let me take you through here. Skin here, then we have the condyle and coronoid process. Lateral to that is the masseter. Medial to that is a medial pterygoid. Anteriorly, we have the temporalis muscle. Further deep is the eustachian tube, and then the deeper to that is the carotid artery. Another important feature to appreciate is that there's significant amount of venous plexus along the muscles of mastication, so this can cause bleeding. Now, one structure we worry in when we address the infratemporal fossa is internal carotid artery. Now, let's just learn how to identify this internal carotid artery at the skull base. So we are just focusing on this area. This is lateral, this is midline, this is internal carotid artery, and here is the eustachian tube. For us to injure the internal carotid artery, we have to, at the skull base, we have to go through the eustachian tube. And there is a thick pharyngobasilar fascia, that's the extension of the prevertebral fascia, covering that carotid artery. So it's not very easy for us to damage internal carotid artery at the skull base. But further lower down in the neck, of course, internal carotid artery can have a curvy type of features. But this important landmark at the skull base is needs to be appreciated. Another question people ask is how do we identify these structures when we are actually operating? Now, one thing we need to appreciate is that the soft tissue moves, but the bone do not move. Now, this is a close-up view of that eustachian tube, internal carotid artery here. And here is a pterygoid plate, medial pterygoid, lateral pterygoid. If you follow the posterior border of the lateral pterygoid plate, that will always take us to foramen ovale. About 2 or 3 millimeters posterior and lateral is a middle meningeal artery going through the foramen spinosum, and about a centimeter posterior and medial is the carotid canal. So this is a relation, and this area, as I mentioned, you have to go through the eustachian tube. Now, further, if you go and remove that eustachian tube, then this is a posterior genu of internal carotid artery. This is the carotid artery running on top of the foramen lacerum at the skull base. And here is the foramen ovale, and this is the foramen rotundum through which the maxillary artery enters the skull base. And this is the skull base here. And if you go and remove this structure further anteriorly, just look at more anteriorly, just to orient again, this is a vertical type of dissection. This is a cut end of the pterygoid plate. This is lateral pterygoid plate, as I mentioned. The posterior border always extends to the foramen ovale. And this is a medial artery, and deeper to that is the internal carotid artery. And if you go and remove the lateral wall of the nasopharynx, then you expose the nasopharynx as a eustachian tube opening. As I mentioned, internal carotid artery is deeper to that in the eustachian tube. And if you do this is by the way, inferior orbital fissure. And if you go up around that area and do a orbitozygomatic craniotomy to expose skull base, and here is this orbital flow here, maxillary nerve, mandibular nerve, and here is a corner space. So having learned the structure, let's learn about the technique of doing the compartmental resection. This was described by our group many years ago in 2008 by something we call transmandibular approach to managing maxillary tumor. So I'm going to borrow some diagrams from that publication. So case in point is a tumor such as this one, tumor of the tuberosteomaxilla. As we learned at the beginning, these tumors can break the pterygoid plate and gain access to infratemporal fossa. Here the tumor has involved the medial pterygoid muscle, and clearly classifying this as a T4B, and we are supposed to observe, give a palliative type of treatment. Now, how do we address this tumor? The address can be addressed by a very simple approach, by a mandibulotomy approach. We do a paramedian mandibulotomy, but later we changed that to an angle osteotomy, because if you do paramedian mandibulotomy, we found that if you put a plate, patient will have significant trismus. Instead of that, nowadays we do ankle osteotomy, and we do not plate this area. We just put a Prolin suture. So after the mandibulotomy, the first structure we identify at the infratemporal fossa area is the medial pterygoid muscle. Now, the first thing we need to do is detach the muscle from the mandible. Now, one important principle around dissecting this area, people who have operated here, we know that it bleeds a lot. Now, the reason it bleeds is because I showed you earlier that there is significant amount of venous plexus along the muscles of mastication. And I always say that consider the content of infratemporal fossa as a venous or malformation. So do not get into the muscle, but go around the muscle. So what we do is strip the muscle from the medial side of the mandible. So medial pterygoid is divided. So next step is exposing the further mandible, infratemporal fossa. To do that, on the posterior border of the mandible, we have the stylomandibular ligament attached. You just have to strip that. If you strip that stylomandibular ligament, you can push the entire mandible laterally, and medial pterygoid is already divided. Then the structure which is holding the mandible down is the lateral pterygoid attached to the fovea of the condyle. So that needs to be divided next. And if you do that, then along with the maxillectomy, you can remove the entire content of the infratemporal fossa with the maxillectomy in this case. So if you do that, and if you just do a close-up of that area of the picture, this is skull base here. The carotid artery will be here. Here the eustachian tube will be here, and soft palate, tensorular palate attached to the soft palate will be at the base. And now the patient which I showed you at the beginning is a typical lady where the mandible is also involved. In this case, of course, we cannot keep the mandible. So this needs to be resected as a composite resection. If you do that, the skin is removed, mandible is removed, and then the maxilla, part of the maxilla also is removed, and pterygoid place is divided, and foramen ovale is exposed. If you just do a close-up of this area, this is a cut end of the pterygoid, foramen ovale here, and the internal carotid artery will be at the depth of the surgical dissection. So in this case, the air will be margined laterally, air will be margined medially, carotid will be margined posteriorly, and the skull base will be margined superiorly. Okay. And this patient was reconstructed by an ALT free flap. Now, doing surgery is one thing. We need to know what is the oncological outcome. To do that, we looked at a cohort of about 282 patients. I will not go into details of it. Out of that, 277 patients were included in that analysis. First analysis we did was overall survival of this cohort of patients with both T4A and T4B tumors, and the outcome is about 60%. Just shows that there is a very good cure rate for this cancer, almost similar to the data which I showed you from that Tata data. But if you compare the T4A and T4B tumors, those we are not supposed to operate, the outcome is almost comparable, 64% versus 58%. Then we further the variable. We looked at the class. I mentioned about the class 1 T4A tumor. In fact, class 1 tumors did better than the T4A tumors, those involved in the mandible and the skin. Okay, but of course they are not statistically significant, so it's comparable. And you look at the class 2 and class 3, again it's fairly comparable, but not significantly, not statistically significant difference, but some difference, 64 versus 51%. But when there is a lateral pterygoid muscle involvement, that class 2, definitely the outcome is poorer, but still it's about 43%. But one important message is that if the patient do not follow up with radiotherapy, it's almost as if we have not touched the patient. The cure rate is only about 11% compared to 64% who have undergone that compartmental resection and postoperative radiotherapy. And then we looked at the pattern of failure of this cohort of patients. The local recurrence was only about 9. And these recurrence happened when there was a lateral pterygoid involvement, and there's non-compliance to that radiotherapy, or perineural invasion was present. And a significant number of the patients had distant metastasis. So to summarize, if you have a patient with a T4B tumors. I hope I convince you that surgery can be offered to this patient. And the type of surgery which I mentioned to you is a compartment resection of this tumor. And if you do that, the outcome is, or whether it's T4A or T4B, is comparable. And definitely we need to consider chemoradiotherapy in those patients. We cannot recommend surgery. Those are the class 3 tumors where we're going to get a positive margin, or unresectable tumors where we induction chemotherapy needs to be considered. So this is the algorithm we follow. A patient with a advanced, means T4A or T4B gingival cancer. If the performance status is poor, we put the patient on palliative care. If the performance status is good, and if a T4A or T4B and class 1, class 2, primary treatment is surgery, followed by chemoradiotherapy. T4B with that class 3, that inferior orbital fissure or pterygomaxillary fissure involvement, we recommend induction chemotherapy. If there is a good response, primary surgery. If poor response, try out the patient with chemoradiotherapy. And recurrence, of course, go for best supportive care. So that's all for me, and I really thank you for your attention.
Thank you so much, sir, for your very informative lecture. I am audible?
Yes, sir. Yes.
Thank you for your instructional lecture, and we have learned a lot. And by your surgery and by your lecture, actually, we in Bangladesh start few cases of advanced oral cancer, and we have some good report, good survival. And now we have 3 panelists. At first, I would like to say something. Our Dr. Rafiq Ahmed Bhuiya, sir, the consultant, ex-consultant of Dhaka Dental College and Hospital, and pioneering the maxillofacial surgery in Bangladesh from very beginning. Rafiq Ahmed Bhuiya, sir, please.
I am very appreciative to you and all the participants. Our speaker is very highlighted speaker. He is well-known maxillofacial surgeon as well as cancer surgeon. So we are very glad for this session. Thank you very much, everybody. Thank you, Masood.
Thank you so much, sir. Now our another Professor Brigadier General Abdul Rauf, sir, please say something about our today's presentation and few comments.
Thank you very much. Would you hear me? Yes, sir.
Yes, sir. Yes,
today's
sir.
Actually the main attraction, the guest speaker, Professor Moni Abraham Kuriakose, and the panelist and the President BAMOS, Secretary General, and other participants. Assalamu alaikum and a very good morning from here, because our guest is from the New York. I think there is a morning is there. So, in fact, I was waiting for this seminar for a long time. Especially, we have a confusion because 2 weeks back I got a similar kind of patients, and is a patient came with the restricted mouth opening. We thought that maybe some other region, but we found after CT scan that infratemporal fossa involved, and also the carotid space involved. So we could not operate properly the patients. That the compartment resection could be the solution of that patient, but as we are not expert on that, we could not go for the compartment resection. So one thing actually I came to know today that not all the case the induction chemotherapy is not working properly, but in our country there are some doctors offering the patient that come to for induction chemotherapy. So I came to know today that not all the cases the induction chemotherapy is not working properly, but one thing you said that if we could clean surgery, if we could operate the patient properly with some negative margin, that clean surgery, the prognosis is increased manifold. So that is the most important. Of course, there will be some chemo and radiotherapy if required, that he told this. And overall, actually, he really, our maximum, so many young surgeons also here is in this seminar, they came to know though there's very good, clean anatomical description of the ITF today. Actually, we came to know. Myself also very clear, especially the total ITF and what is the danger of this operation. And if we know proper anatomy and before surgical approach, I think our surgery will be successful. So thank you very much. Thank you very much for this presentation. And also our in the learning phase, our surgeons will be definitely benefited. So thank you for long way. You just attached to us and joined us to share your knowledge, share your some experiences. So thank you once again. I'm from the armed forces. We're also doing the surgery. So pray for us and we hope to meet you again. Thank you very much. Thank you all.
Thank you, sir. Thank you for the comments.
Thank you so much, sir. So before I'm going to question and answer session, we have another panelist, Professor, our another professor. So please, madam.
Professor Tarin Rahman.
Professor Tarin Rahman, madam, please say something about this. Madam, Tarin madam, please.
Assalamu alaikum, and my salam and respect to Professor Moni Abraham and all my teachers. Thank you. Actually, the presentation was very nice, and I think it will be very useful for our surgeons. And we have most of the patient, maximum of our patient come with stage 4. And we have many patients in Buccal mucosa involving retromolar trigon, which may, or in most of the cases, they involve the intratemporal fossa. And sometimes we are puzzled, or we are in danger to take decision, what to do with the patient, as we have so restricted facilities in our country. Surgery, we can do the surgery, and many of our young surgeons, they are trying to do fossa clearance, they are trying to do, but the adjuvant therapy or the supporting therapy, our facility is very low here. So I hope in future we will get, our government will arrange, and also our private sector will help us in this for the adjuvant therapy or combination therapy. And as we have learned, and all of us surgeons have learned from Professor Moni Abraham, the compartment surgery in such a nice way, I think it will very helpful, and I express from my deep of my heart my thanks to him. Thank you. Thank you, John.
Thank you so much, madam. Now I'm going for some session. There are lots of questions in the chat box. I think Professor Moni Abraham sir will enjoy. First question is, why, one of our colleagues want to know why the resection is called the compartmental resection.
Okay, so let me take that question. The reason why we compartmental resection is that we are removing the entire compartment. So traditionally we do surgery by say 1 centimeter or 1 centimeter margin around a tumor. You feel for the induration, go 1 centimeter around, 1.5 centimeter around that wide excision. about section has come in sarcoma, where you remove a compartment of that tumor, the involving compartment, because progressively going similarly around, but it is along some of the nerves and muscles and so on. So we are removing the entire compartment rather than just removing one
And
centimeter.
another question is, how we can define the inoperability? How do you define the inoperability?
The main inoperability going to get a close margin or positive margin is inoperable. So again, at the end of the operation, if I'm going to get positive or close margin, it's inoperable. Okay, by just looking at the image evaluation. But even after evaluation, sometimes we get a close positive or close margin. That is unintentionally. So intentionally, we can predict which are the patient where we can get a positive or a close margin. So these are the tumors which extend along the pterygomaxillary fissure into the inferior orbital fissure and gain access to the intracranial compartment, or those tumors tracking along the mandibular nerve through the foramen ovale to the intracranial compartment and later to the cavernous sinus. So whenever you're suspecting that there is a tumor on the posterior wall of the maxilla, assume that there is a spread along the posterior superior alveolar nerve. In this case, we have to take an MRI scan. Similarly, if the tumor is involved in the lateral pterygoid, this needs to be suspected. Get an MRI scan, contrast and enhance an MRI scan. If the tumor is involved at foramen or the nerve, then we have to consider inoperable.
So another question, in case of internal carotid encashment, it is possible to detect in CT scan?
Yeah, absolutely right. It's a criteria is fairly well defined in the neck literature. If the tumor is encased surrounding the carotid by 270 degrees, then most likely the tumor, there is invasion of the carotid artery. This is a definition we use for the neck vessels. But in skull base, if the tumor is abutting the carotid, it's almost as if there is a carotid involvement. So we should not venture into surgery in those situations. In the neck, it's different.
Another colleague asked a question. Is it useful to use subtemporal, preauricular, infratemporal fossa approach instead of mandibulectomy?
Yeah, so this is a traditional approach used by ENT group for treating schwannomas or paragangliomas, where the tumor is around the internal jugular vein, tumor is around the condyle, it has not come anteriorly. In this situation, we are just coming only up to the facial nerve. Now, if you go from the preauricular or postauricular infratemporal fossa approach, like fish approach, facial nerve is in our way. Now, our tumor is origin is in the oral cavity. So the nerve will come in our way, facial nerve will come in our way. So that is not a good approach for squamous cell carcinoma.
Okay. Another question is, during transmandibular approach, when we do the angle osteotomy, one of our colleagues asked, in case of ITF clearance, so the role of how you will prevent the trismus, that is the role of prolene to fix the mandible instead of plating, you have shown in your cases. So I think he wants to know elaborately.
Yeah.
Can you tell?
Yeah, absolutely. So we used to do the paramedial mandibulotomy for infratemporal fossa and found that almost all the patients have significant trismus after radiotherapy because the condyle get fixed into that masticatory space and in the glenoid fossa. So that condylar fixation scarring is a major problem. So to get around the problem, we make that osteotomy at the angle of the mandible just ostectomy, remove that, then swing the mandible laterally, and then remove the tumor. Then put the mandible back and put 4 holes on the mandible and use a proline, 0 or 20 proline, a figure of 8, and tie that. This mandible will provide some cosmetic type of support. And then other thing is that it forms a pseudo joint at that area. So even though the condyle get fixed, the angle will move, and then the trismus can be avoided.
Thank you, sir. And another question is, what is the indication of hemimaxillectomy or maxillectomy in T4B class 2 or 3 class 2 or 3
Yeah.
tumor?
So most of the time, a tumor on the posterior part of the buccal mucosa or retromolar trigone, there will be extension to the maxillary tuberosity area. To get clearance around that area, you take the posterior part of the maxilla along with the mandibulectomy. So some people call bite resection. So this is traditionally done to get a negative margin.
Oh, our one of colleague, Dr. Mohiul Alam Siddiq asked, during operating T4B tumor, is there any role of prophylactic parotid deep lobe excision, as masseter and deep lobe lie very closely? Is there any role?
Okay, let me, if I show that diagram, there is no need for that. The reason is that, let's go back to my, okay, let me show that, can you see my screen, the diagram, my presentation? No. Okay, let me.
Not yet.
Not yet, okay. So there is no need to do that because of the anatomy around. Okay, let me start. I can't find my presentation, but doesn't matter. Okay, so see the deep lobe of the parotid is lateral to the parapharynx fat. So parapharynx fat plane is what separates the parapharynx space from the masticatory space. Oh, so that's a avascular plane you take. So if the tumor involved the parapharynx fat, it's almost like carotid is involved. So almost, I have not seen a case where there is a parapharynx fat involved. Most of the time, tumor goes goes along the medial pterygoid or lateral pterygoid to the skull base rather than going posteriorly. So deep lobe tumor parotid, we don't have to remove.
Okay. What are the difference in treatment outcome of wide local excision and compartmental resection in class 1 ITF cancer? Class 1, you have, in your classification, what you have said in class 1.
Yeah, sure. So see, the important thing is that wide excision can be practiced judiciously. If you look at the paper from Tata, they got almost similar result as what we got, and they did not practice compartmental resection. The reason why we propose compartmental resection is that it's a technique which we can do it in a very, very standardized fashion. It can be taught to the students in a very structured fashion. So we encourage people to use in a structured type of resection. So if you do that, it doesn't matter, I operate or one of my colleagues operate, we follow the same steps. So you get almost similar outcome. Otherwise, it will be dependent on the experience of the surgeon. Some surgeon knows where to get a more deeper, more wider margin compared to other inexperienced surgeon. So we recommend compartmental resection. The 2 types of compartmental resection I mentioned: one preserving the mandible, the other one is sacrificing the mandible.
Okay. Another question: why pterygomaxillary fissure is difficult to clearance? Pterygoid resection isn't quite enough.
Yeah. So the problem is that when the pterygoman easily see in our CT scan, this tumor, if there is enhancement around that area, we have to assume that the tumor has gone along the posterior superior alveolar nerve, that we can't see it. So we'll have to assume, because that is how the tumor spread to that area. If it has gone there, the chance of positive margin is high. So it's predicting, we are anticipating that I'm going to get positive margin. If I get positive margin, I've shown our data, only 11% overall survival. Okay, so we cannot, we should not venture into surgery. Rather, give induction chemotherapy, look at the response, and then try it for surgery.
Another question from Dr. Nitish Kishan Das. He's a very fantastic surgeon doing cancer surgery. And he asked the question, if lesion involves posterior styloid parapharyngeal space, is it operable?
It's not if it is squamous cell carcinoma started from the buccal mucosa, gone to the posterior parapharyngeal space, not operable, because in that case the carotid would have been involved. But if it is some other tumor, for example, a tumor from the parotid going to the that is operable, but not a squamous cell carcinoma gone to there to that location.
So another colleague wants to know, what is the posterior to anterior approach?
It's posterior to anterior approach is the after exposing the infratemporal fossa, we are coming from posterior to anterior. Okay, so you are if you remember, so first structure we are detaching is the medial pterygoid or ramus of mandible with masseter, and then identifying the maxillary artery, and then for posterior to anterior. So that's the approach we do, because that's we go through the parapharynx fat plane. Anterior to posterior, the problem is that we will not get an opportunity to ligate the maxillary artery. That can cause bleeding.
Okay, thank you. No more question in my chat box, but personally, I have some question to Moni Abraham, sir. After seeing some advanced lesion and T4B lesion and ITF clearance and learning from you, I have done few cases, and I have studied about 170 cases of advanced cancer, which was T3 and T4A and T4B. And overall survival is 73% and disease-free survival is 62%. But the patient which I have lost in 1 year, all of this patient is due to chemotherapy and due to post-chemo pneumonia or cardiac arrest. So what is your comment about this?
Yeah. So I always say that giving chemotherapy is not like walk in the park, particularly our patients who are malnourished. Taxol platinum 5FU is very, very challenging. We lose patients from that. So we don't take the recommendation to give chemotherapy lightly. It's a very serious decision. We take it only if there is a borderline resectable, I mentioned to you, at the pterygomaxillofacial area. Otherwise, we don't give just induction chemotherapy. Sometimes we do if we have a delay, there is some delay to get to operation theater or something like that. Sometimes we give induction chemotherapy. I agree with you. We should not give induction chemotherapy just very lightly.
Thank you, sir. Thank you so much once again. And now I would request our Professor Ismatara Haidar Madam, the President of BAMOS, to conclude this session. And thank you, sir. Madam, please.
Thank you, Professor Moni Abraham. Kuriakose, for your excellent presentation of advanced buccal mucosal carcinoma with ITF clearance and compartmental resection. I know it is your very interesting and your favorite topics. So during your presentation, we are knowing the anatomy of the infratemporal space and the classification. And from this classification, which we can surgery and which we cannot do the surgery. So it is very important. So you know that in our country, most of the patients are class 4A will be like this. So we are started in the infratemporal space clearance, that is compartmental surgery we are doing now in the Bangladesh. And because we are doing the free flap surgery, so now it is easy for our surgeon. So our young surgeon are doing the compartmental resection and after their surgery. So I think it is good for the patient because every patient are in advanced stage. So if we are not doing the surgery, the patient are very poor condition because after radiotherapy and chemotherapy, most of the patient are come again with the recurrence. But in your classification, you mentioned that class 4B, 1 and class 1 and 2, we can do the surgery. And survival rate is 55 to 60%. So we are very much interested in that cases that we can do the surgery. But in case of class 3, we can do the radio induction chemotherapy, and after that we can do the surgery. So it is a good message for our doctors, young doctors, and many of the surgeons here. So very excellent presentation, especially your anatomy. The presentation of the anatomy of infratemporal space is very nicely presented. And you are very much interested to do the mandibular angle osteotomy. And then it can reuse it in the proline because there is pseudo joint and there is much less chance of the restricted mouth opening. So it is one of the very good lesson for us. And one thing that our maxillofacial surgeon is Bangladesh are doing very good surgery for cancer because they are knowing the anatomy and they are knowing the surgery. So doing good surgery in the Bangladesh. So thank you for your excellent presentation and for your doing this presentation. We can learn many things for our young surgeon, young trainee, they know many things. And I would like to thank our panelists, our respected teachers, Rafiq Ahmed Bhuiya sir, our colleagues, Dr. Tanin Rahman and Brigadier General Abdul Robs. I like to thank for coming here and attend this webinar. And also like to thank our participants. I think our participants were 107. So it is a very good participants in this webinar. So it is a very good thing for for us. And I'd like to thank our Dr. Abdullah Masood, our moderator, and IT technologies, Dr. Manjuri Mahmood. So they are doing their job very nicely. So thank you very much, everyone. And thank you again for Moni Abraham Kuriakose. Thank you, sir, for your excellent presentation and join with us. Thank you.
Thank you. Thank you, Professor Haider, and thank you all.
Thank you.